with Pakistani government, again on snakebite and health system development. That's me. And like Michael Larkin, I love cricket. I played cricket at the first class level when I was in university. Not a good cricketer, so that's why I turned into a public health person.
There you go. Thanks, Asaf.
Thank you. All right, Annie, are you back online? Can you hear us?
Yeah, I can hear you now. Just disconnected my monitor. Sorry, I don't know why.
That's all right.
Sort it out.
All right, just a quick update before we hand over to Michael.
From me?
Yes.
Attended the sexual health conference a couple of weeks ago, and I'm just working towards getting my everything ready for my confirmation in November, late November. I've got concept sheets into Access, making inquiries around Strive Plus data, looking at the Atlas data. I've got an expression of interest in there for my proposal for access to data. I'm waiting on what I need to do around ethics, etc. So yeah, just waiting for that, and then I'll need to start working out how to manage that data. So that's for my main project.
Okay.
Yeah. Otherwise, yeah, still developing some of my other project areas. So that first project is around mapping trichomonas rates around Australia. So yeah, just concentrating on that one at the moment.
Okay. All right. Thank you very much, Annie. All right. Thank you very much, everyone. I think I now hand over to Michael and team.
Thanks, Barbara. Okay, I'm just going to give a bit of an update on where I'm at. So I want to show everyone just a bit of a map, what I've put together about the audit part of my project. Essentially, the last time I presented, I was really interested in looking at hepatitis B management and around the clinical information systems. Some of the feedback that I got was that it was maybe a bit too close to my work, because for my job I was doing a lot of this work anyway, and that it was a little bit probably too much like I was evaluating the work I was already doing. So I've gone back and tried to review the audits and make them a bit more academic, and I guess coming out of that process, I'm now looking at doing a more intensive detailed audit, looking at a range of different variables and how those variables may impact the access to care and what kind of care clients are receiving. Then the next steps to go in and look at doing a series of workforce interviews to flesh out, well, what's the workforce perspective on how we can improve access to care and improve our hepatitis B management, and then also identify some clients with a diagnosis of hepatitis B, and then get the client perspective as well. So then that'll be sort of bringing all that together. So what I wanted to show today is the audit phase, because that's what I've been focusing on. I've really broken it up into 3 steps. Just focus on one chunk at a time. So my goal is to hopefully have these audits complete by the data collection completed and by the end of the year, and then work on analysing the data over January, and then hopefully I'll have a paper ready, like a draft paper, sort of mid-February is the plan at this stage, because that'll be 1 year into my PhD, the 1 year review, and I'm already getting a 3-month extension on that with some other extensions I've had. So yeah, that'll be the plan. So I'll just figure out how I can bring this up. Share screen first, that thing.
Yeah. And then pick which window you want. Show all windows.
Okay. Show all windows. Here we go. So this is just so, can everyone see that?
You want to minimize that thing on the side.
That one?
Yeah.
Okay. So this is just some thinking about the actual audit process. So what I'm really interested in is looking at across 8 Aboriginal community-controlled health services, looking really over a chunk of a year period. But some of it's the whole sort of someone's time they've been enrolled as a current client of the health service. Now, I'm using current clients, which is the definition of a client who's accessed the service 3 times in 2 years. I've got a lot of data that I've collected on clients who are categorised as transient clients, but obviously chronic care management from a transient perspective is a lot more challenging. So I'm not including that within this data analysis, but I'll provide some data on that separately. But essentially what I'm interested in is getting a picture on, across those services, how many clients do we have with a diagnosis of hepatitis B? And then of those clients, how many of those clients have had an initial assessment? Now, there's a few steps involved in an initial assessment for hepatitis B. There's some blood tests involved around disease phasing. There's also some different scans like to essentially look at if there's any scarring on the liver and look at the liver health. So I'm looking at the combination of those. There's probably about 6 steps in initial assessment.
Yeah, one step. Current clients, which is your definition?
Yeah, the current
All
client.
clients of an AMS or current clients 3 times?
Yeah, just the current clients I'm looking at.
Only the ones that have been in 3 times in 2 years?
Yeah, so defined as current clients. I'm pretty sure that was the definition. Yeah.
For a AMS client.
Yeah.
Used in the National KPI report.
Yeah, so that's what I was using as a structured definition, but I've got flexibility to, essentially I'm excluding.
You pick up many clients if you use that definition.
Yeah, well, we are still
3 times in 2 years.
Yeah.
So we're finding about 60% of clients in AMS are current clients.
Yeah.
40% are visitors.
Yeah, so I'm not excluding all those other clients. I'm just for the data analysis. I'm still anyone who's got to define as transient. I've still got collecting data. I'm only collecting the basic data though, and if those people have had a check within the last 12 months. So I am accessing that data, but I'm not going to go. I'll go into the detailed level of variables, but I'm not including them in the same analysis group because I think that would be a bit challenging to expect someone to be. If someone's primary service is somewhere else, yeah, but I'm excluding past clients who.
So, but I think it's important when you write a paper to define who your current clients are. Which definition are you using?
Yeah,
you just said just then, anyone who's had a testing last year. But actually current clients, when you're writing your paper, should be defined as they defined in the, you can easily say current clients as defined in the National KPI report.
My understanding, Michael, is that you are using this to see, and that's my understanding, Michael, that the opportunity to interact with the health service provider or health services, if they have 3 opportunities in the last 2 years, it means that they are clients or community members who have more opportunity, a regular opportunity to be recalled, monitored better, and provided care from a continuity of care framework. Whereas transient clients have less opportunities and might be difficult to provide care. So that's why at this stage your focus is only on those who have at least 3 opportunities or 3 interactions.
Yes.
I'm not questioning why.
No, I just need the specific definition. Yeah.
And the
I know
testing done in 1 year or testing done in 2 years? That's the question, right?
Oh, well, no, I'm picking a 12-month period. No, that's about which definition you're using. Because I guess you can refer to, like you were saying, the Commonwealth definition there. So I've got to be clear on that.
Current client, as you suggested, for 2 years, but rather monitoring, from a monitoring perspective, testing was done in the last 1 year.
Yeah.
Okay,
No, I know what you're saying.
They got, so you did January to December and they got their test last December.
Yeah, well, I'm picking a 12-month period to focus, and if people have had tests outside of that, well, then I suppose that may happen sometimes. You know, I could make it more broad, but what I am doing is I'm collecting data on an initial assessment as well. So I am looking if someone's ever had an initial assessment as a record within that service. Plus, then I want to look if there's been monitoring within 12 months. So I'm not limiting myself to the 12-month period for the initial assessment. That will be the whole history of the client's clinical record. So the different, and then I'll also be looking at for clients if they are aged over 50 years, if there has been ultrasound and AFP blood testing for surveillance for liver cancer.
No, I think we need to go back because I'm thinking about the test in the last 12 months.
Yep.
So you're going to go back and see if they've ever had an initial assessment.
Yes.
Why would you restrict testing to the last? So if they're
because the
positive,
clinical
if they're
guidelines.
positive, right?
Yes.
So it should be monitoring, right? And some people should be on treatment, but it should be monitoring in the last 12 months, shouldn't it?
That's what
So
I've got.
If they
Yeah.
had their initial assessment 10 years ago, you're going to pick up that. Are you going to look at the last 10 years, or are you just going to look
No.
at the last year?
Because you've got, the way I've looked at it is I'm just picking a initial assessment is going to be the whole record, but for the monitoring, to look at the whole history of someone's monitoring would be such a huge undertaking. So I'm looking at just picking a 12-month chunk and say, okay, let's just take a 12-month sample and see what happens in that 12 months.
Okay, so
And everyone
would there
should
be
get a
scope
check.
to extend it to 2 years.
Uh,
In the last 2 years,
yes.
rather than just the last year. So what happens if your period's January to December and the person had their test, who's a current client, 3 times the last 2 years? The last time they had their Hep B test was December last year, just outside your year.
Mm.
Yeah.
Yeah, there will be a way that I could capture that. I could extend it to 2 years. Yeah.
Yeah, I think 2 years would be better.
Okay.
If they're a current client 3 times in 2 years and you're testing, monitoring over 2 years, I don't think it's too burdensome, but it might give you a better, because if, say, depends when your period is. So say when your cut-off period is July, say for instance, and they had their test in August and they're not due for their next test in August, you'll pick up one but not the next one.
From a chronic care management model and from the protocol, agreed protocol by subsidy, if a test has to be done within 1 year, then it has to be done within 1 year, right? And if a person has not, so in a way, I mean, I'm not saying that he should not do it. That's a different question. I'm thinking conceptually that what he's looking at. So there are 8 organizations, and there's a protocol that once X is done, the Y needs to be done within the next particular period of time. Whether that Y was done, Y test was done within the stipulated time frame or not. So
but guidelines are guidelines, and people are busy in these services, right? And so 12 months. So retesting for an STI should be done in 12 months, and retesting should be done at 3 months after a positive result. But we kind of give clinicians 2 to 4 months if we're analysing data to make sure that so you've got to have some. I mean, people are busy and people are not always in community.
I think that makes a lot of sense because the next phase, which Martin will expand on, is the going and talking to the stakeholders, service providers, managers, and finding out from their perspective what is happening and why it's happening. So if, for example, through this exercise you find out, yes, monitoring is done, but not within the stipulated time, but maybe 6 months out of it, then you could ask a question that what is putting us behind the timeline, right?
I mean, 1 year is a 1 year period, but I think you've got to give some leeway. And
So
your current definition of a client is 3 times in 2 years. I think your testing should be done over 2 years. Then you'll be able to see like 1 test was done for 50% of the population in the 2 year period, or 2 tests were done for 20% of the population. I think it just gives you a bit more
and maybe
credibility.
these two
Vaccinations are not done on time.
absolutely,
A lot of the time
no doubt about that.
for
But I agree with you that the things written is something, but life unfolds in a very different way in an organization. And maybe out of this, a recommendation would be that yes, clinically it is needed in 1 year, but there needs to be a extended time frame when it comes to regional health services. That might be a policy outcome of that. That my manager, my service provider are suggesting that within the context of our work, it's not possible.
Yeah. Well, I mean, the guideline, but I'll definitely look at extending that because I'll take your point. It's just data that'll be interesting to show them because I from what I've done so far undertaking this work, I don't think there are going to be a lot of instances where it's turned that, someone had a test 13 months ago and then, I know there's a difference between someone who hasn't had a test for 5 years and someone who had one at 13, 14, 15 months ago. But I think if I extend it a little bit further to allow that, then that'll pick that up. So I think, but that's, I think that's, thanks for that feedback. In relation to just continuing on with the data variables, I'll be looking at collecting, the ones in red are the main things which are going to be, I'm really interested in knowing, because that's the key elements of your hepatitis B management. So that monitoring, what we're really looking at there is a viral load test and liver function test. Now, hepatitis B is such a case-by-case kind of virus where every individual may need certain additional testing depending on the nature of the virus and nature of other health complications. But the basic standard things that everyone should really be getting is liver function tests and a viral load. So that's what I'll be using as the measure for the monitoring. I've already spoken about the HCC, hepatocellular carcinoma screening. So what I'm interested in is also collecting information around age, gender, years since diagnosis, or the date of the earliest surface antigen pathology diagnostic tests within the clinical records. Chronic disease comorbidity, client contact within the past 12 months. Documented on if the diagnosis is documented on the main summary, if there's a recall set for monitoring, if a client's ever seen a specialist for that condition, if the client's on antiviral treatment, and also the specific recall that's been used on the client file. The service level variables, I'll be looking at if there's been a specialist liver clinic within the past 12 months, that period. I might have to extend that now to 2 years if I'm looking at a broader time frame. A remoteness classification, GP access, full-time, part-time, and the number of clients that a service has, if it's greater than 10, less than 10, I'll come up with some sort of groupings for that. And then I'll have the aggregated data across the 8 services. Some of these specific numbers might change, but it'll probably then be looking at, the numbers and percentages of clients to gather information around, well, how many people have had an assessment across the services that are included. Your average ages, your gender mix. I'll be looking at, the average sort of time since diagnosis, the percentage of clients who had recalls, the percentage of clients who've had their condition documented in the main summary, percentage of clients who've ever seen a specialist, the average numbers of recalls within a service. I mean, this is stuff which, there's been audits that I've read and looked at which have gathered data on, screening. How many people have had all 3 tests done for screening? Or how many people have only had, maybe one of those tests? There's been different audits done around management in different ways. How many clients, looking at sort of, as I mentioned earlier, the hepatitis B viral load DNA test as a marker, how many clients have had that. But I'm sort of looking at going to probably one step further, that I think this is probably the new sort of area of research, which I think is sort of the exciting part of the work I'm doing with the focus on the clinical information systems, is looking at, well, how many kinds of recalls. So I've looked at some services and they'll be using, say, 4 different recalls around hepatitis B management, for example, and they might be something review nurse, hepatitis B, it might be, review specialist, and there's a number of different recalls that are being utilised, and that's for clients who have a recall. But I guess what I'm interested in then is, okay, is there impact then on the number of different recalls within a service, on then how that can impact care? Because we know that for good recall management, for chronic disease management, that you want to have one recall consistently being utilised within the service. And you want to have someone within the service, which will be the next phase of my research when I work with the workforce, is, okay, who within that service, if anyone, is in charge of managing those recalls? And then what are the challenges within that service of creating a recall list? If you're utilising, for example, 4 different recalls, that makes it, a lot trickier. So that's the kind of, it's quite a lot of detailed information, as you can see. And then the analysis across the 8 acts is sort of what I was talking about then. So looking at if any of these variables, whether it's age, gender, if there's a recall set, have an impact on the levels of whether someone's had monitoring within the last 12, 24 months. Just giving it a bit more thought about some of the considerations, limitations I've said about the transit.
This tree number 1 is for the individual.
Yeah, so that's the individual. The first area is the individual's data that I'll be collecting from the audit. The service level is stuff that isn't going to be collected from the audit, but that's more knowledge that we have in our organisation.
So how does this work practically? You get the list of all current clients, and then you look on Communicare and find Hep B surface antigen patients that have been positive for the last year or within the last 2 years.
No, ever. So I have a complete, and I've already undertaken that work as a part of my work at Access. So we already have a list of those clients.
Yeah.
It's now though, I haven't gone in and done this very detailed level audit.
Service, you'll get the surface antigen positive clients, and then you'll pull their files.
Yes, and do a case note audit.
Manually.
Manually do a case note audit.
What do you think the positivity rate is in a service?
It'll be, I don't know about rate. I'd have to then check it, then the number of clients to get that, but I can get that information.
Like 3% of clients is percentage of positive, or 5, or
it's the numbers of. I'm probably looking across the 8 services. I'm only going to have probably about 60 clients. That I'll be focusing on. And so that's what I've sort of noticed some of the limitations. That 5 of the services have only got a handful of clients, and then the other 3 have probably got anywhere from 15 around that amount. So it's not large numbers. So it's manageable, but it also, I think, as I'll sort of talk about here,
and that's why I think the 2 year is quite manageable as well. There's only 56 or 60 patients across that area. So it's 2 years manageable.
So I had thought about maybe only focusing on 3 services for this detailed audit who had more clients, because there's 3 services of the 8 who've got more clients. The other 5 have only got a couple clients. But I thought, well, the data on those clients can still be interesting.
No, it's good. I just want to get a sense of that.
Yeah. So we're not talking very large numbers,
Michael, I think with the number only 56 or 60, with the number of these variables which you think might or do impact on their care or continuity of care, I think the number is quite small to reduce it from 8 services to 3. So I think 56 is still a valid number, but less than that would be difficult to say whether age has any influence or whether gender. You can only speculate.
Yes.
Even with 56, you can only speculate.
Yep.
And then consult with your colleagues in the services and the staff.
Having that comparison too, from a service to we've only got a handful, it's easier to keep track of people and work the medical system easier than it is if you've got a few more people.
So these are the kind of thing. There's I guess I'm thinking go in, get as much data like this, and then there's lots of different ways it can be.
Michael, just a thought. I'm very much into case studies. I've done a lot of 30 case studies. And they give a feel for what has been going on for this particular person. I'm not suggesting to increase your workload.
No.
And without actually consulting and talking to the person, because that would be another ballgame and ethics approval, etc., to talk to the person, the individual person. But I think if you have sufficient information, one could see a patient who has got a full battery of tests done, on time done, all the good care received. Who's that person compared to a person who has not done or a patchy testing, delayed testing, and give a feeling as part of your paper. Maybe
Yeah.
half a page case study and half a page of case study of the good one and the patchy one.
Yeah.
What do you mean, the patient?
The patients as a case
Yeah.
study, that if a person, this person of this age, this gender, living in city or in rural area, has been in touch, has been a regular customer or client, etc., etc., and that has led to a more and that over there, blah blah, something like that. So
yeah, well, there's scope for that, and I mean, I'm going through this work from my work perspective. Haven't been going into this level of detail, but the stuff that we have been looking at has indicated some examples where you can just see where a client's been screened incorrectly, say 4 times, and then eventually someone's come along and ordered the right tests, and it was someone who'd been living then with chronic care B, and there was no care, no diagnosis. So yeah, there's specific examples I can pull out and potentially develop as case studies. But
that speaks to the health service characteristics, which is so you've got GP access, right? But turnover of staff and I mean, somebody might not have been tested, but because that's the doctors, people don't know what they're going to be tested for. The doctors are not testing right. So if there's been a service where there's been a high turnover of clinicians, either nurse practitioners or general practitioners who haven't offered the right battery of tests, that should be captured somehow.
So should this be then, those service level variables, should they potentially come into the second analysis paper, which is more the workforce service perspective on what the issues are?
Yeah.
And then I'll speak to the service about, well, what's, during this period of time, what did you have access for GPs? What was your staff turnover issues? What's the nature of the access to care in terms of the funding you've had, or if you had an Aboriginal health workers involved in your service, you've been able to go out and do work in the community. Maybe that should be fleshed out a bit more into the second study, and just keep this just purely the audit data.
Michael, just here, Barbara, sorry. Annie did have a few comments, and I'll come to you, Annie, in a second. But just in relation to what you've just said, I think it's important that you still have some service variables. And I can send you a tool that the 120-170 used, where you can, so that not only remoteness classification and GP access, there's a bit more information you can collect.
Okay, great.
As part of the service variables that you can analyze against your initial assessment and the like. So I'll send you that tool after this meeting that you can add to some variables. Because I think it's very important to know what service variables exist that may have an impact on patient care.
Yeah, that'd be great. Thank you. And also, if you have like the individual level variables, I mean, I've just sort of looked at a few papers and used my existing knowledge to come up with that list. But if there's things that I'm missing there as well, which you think should be considered, please.
I'll try to find, because I think one of the things you've missed is Aboriginality as well, because you may have some people at your health service, though it's an Aboriginal health service, there might be non-Aboriginal people there. So your care, the care that the patient may get may depend on their Aboriginal status.
Yeah.
So for example, that's one of the things that you've missed out. So I'll just look at the ABC and see if there's some variables you're missing. But also back to what you've just said, I think at a more in-depth analysis, I think there's also an extra conversation you need to have about the health service in an in-depth way.
Yes.
There are the variables in the analysis, and then there's the in-depth conversation which you can have.
And Barbara, what do you think about the best time to sort of collect that? Did you think I should be looking at those service variables a bit more broadly than in the second sort of phase of the research, where I'm more focused on what are the workforce perspectives and the service impacts on this, and then just keep the data variables situated on the audit?
Yes, so there are data variables for the health service in the audit, and then there are the second phase, as you've just said, a more in-depth conversation where you're looking at the health workforce, but you're also looking at the system.
Yeah.
What is it about the system that might have an impact on care delivered?
Yeah.
Okay.
And then I can bring it together in the second paper, and then bring the lived experience and clients' understandings into the third.
The third phase. So just to Annie, because Annie had been writing some comments in the chat, which I think we weren't concentrating on. So.
Yeah, okay. Annie?
Oh, hi. I was just saying, just your definitions using the word client, current client, because I think there's always some confusion over the terms. And when you use current client, and I know you do a lot with Communicare, current client set by your system. So that can be just one visit in 2 years, which is quite different to the Australian Institute of Health and Welfare, regular client. So when you compare it with NKPIs, it's regular client. So I suppose it's just being clear about that. But if you're saying current clients,
no, that's a really good point. Yeah.
Yeah.
And look, to be honest, that's an area that I'm learning. So very good. I need to go back to. I'm working on this with a nurse who's really 100% Communicare expert. So and understands.
Is that Beth?
It's Beth. Yeah.
Yeah. So she knows that. So for example, at our service, 1/4 of our regular clients are. 1/4 aren't regular clients, are transient patients.
Yes.
Are actually regular clients. So it actually gets really difficult to define that population. They just, especially where there's a lot of transient clients.
Yes. Yeah. Yep.
So the AHI, the 3 visits in 2 years is a good definition, really. But it's not easy to pull off Communicare, actually.
Yeah. And we've been noticing that sometimes that someone might make a phone call and then they'll write that down as if it was a client contact.
Correct.
So we've actually had to go in and say, no, this client should be a past client.
Yeah. Or if someone turns up to a service because there's sorry business on in that community and they might have a wound that they need dressed 3 or 4 times, then they become a regular client.
Yeah.
Which means they wouldn't be receiving their Hep B routine care from that service.
So I don't know how.
It's quite tricky.
Yeah. So what we are doing from a work perspective is when we're providing a series of recommendations back to services, we're actually talking them with the service about, well, how do you want to do your recall management? Realistically, what do you want to do with these clients? Because for some clients, it might be that you need to ring up another health service and it's actually discussing the care with another clinic. So those kind of from a work perspective with this project, those kind of individual client-based decisions are easier, not easy, but they're easier to manage because you have more flexibility. But from an academic perspective, when everything's got to be clearly defined and, I've got to have set definitions and I can't sort of make it up and change things as I go.
It's easy and hard. It's just about deciding what that definition is. And I take on James' point that you probably need to be broader for 2 years, but as we know in AMS, it's every 6 months they should be doing their screening kind of monitoring tests for people with chronic Hep B.
Well, 6 to 12,
ours is
this is the thing, it depends. If you're on antiviral treatment, it's probably then 3 to 6. So
I don't know, but
this is why I've just tried to pick one area, and Hep B is tricky.
So like what your problem is you're using a live database, and the definitions are different than when you academically trying to pick something up. But Beth should be able to write you an SQL to pick that up. She can write an SQL of regular clients that are also current. That's how I end up defining.
Yeah, okay. That's something definitely I'll be following that up.
Yeah.
A clearer definition on that.
And all of you, what you mentioned, I am considering the number is rather small. It will be absolutely important that phase 2 of the study in which you go and consult with the service providers and the managers that what are the factors. This is what the numbers have informed me.
Yes.
And sharing those numbers with the healthcare providers and asking them, because whatever you do with the 56, you cannot claim that GP access is or is not a major factor in determining continuity of care, or because there are only per service 6 or 7 clients only. And out of them, some will be rural, some urban, some women, men. So there are quite a lot of variables which might impact.
Yeah.
And picking out on one with such limited number is very difficult. Therefore, the narrative and the qualitative information provided by the healthcare providers that what is going on will put some meanings to these 656.
Yeah.
Getting the meaning why it's happening is will essentially come out from their narrative.
Yes.
People's narrative.
Now, I reckon that's spot on, Afzal. Yeah, and I think thank you everyone for that feedback, because now that's becoming clearer in my head that definitely those service level variables should come in the second phase as a narrative and as a perspective that if that, when I'm talking to the service and all of a sudden if that comes out, the conversations around GP access, and I'll still have all this data for every service stored, so I'll be able to refer back to it and do a comparison if required.
I'm not suggesting, Michael, that you should not have the numbers on or information on GP access in phase 1 in this study. The number, you can generate the information, but ascertaining means will come from the focus group discussion or in one-to-one interviews with these for the phase 2. So I think the numbers can be calculated. For example, specialist clinics, are they there or not?
Yeah.
It could be included in this phase.
Yes.
But the meanings will be coming from the second phase.
Yeah.
So this is like a situation analysis, and that could be presented to the people. That's all. What other things?
Thanks for that feedback. So I just wanted to touch on a few sort of considerations or limitations that I've sort of been considering is around this issue around transient client data management, which I'll have data on, for example, how many clients who are classified within that service of transient have had a check within the past 12 months. And it is, it's less, which you would expect. However, I've just noted that there that I'm aware of the fact that it wouldn't be appropriate to include transient clients into the same group when you're trying to manage the same analysis group as current clients, because that would be unrealistic then. And I've just noted the second box down under the limitations is just what we were talking about, Annie, about the challenges of that. This really is the viral monitoring and the actual management is going to be, it's really is quite case by case basis, and there's a lot of different factors such as if someone's on treatment, and I think part of the worry is that there's a large number of clients who are getting no monitoring. So I guess we pick. I'm not going to get too bogged down in identifying. At one stage I thought, well, I could pick if this client needs 6-month monitoring or this client needs 12 months, and then you could review that. But you're getting into a phase then where I'm actually going to have to look at things and make clinical judgments from case notes. So it's just not appropriate. It's similar with the HCC screening. I've picked the age factor, so 50 and over, because that's the current guideline. But we know that you have diagnosis below 50 anyway, but that's not the issue. There are other things here where it can be, if someone has, cirrhosis, for example, you should be getting monitoring more regularly. But because that's not often documented, it's hard to even know. So I guess I'm just thinking, what's one factor I can pick, which is easy to determine, and that's age 50, over the age of 50. Okay, that's going to be at least to be one measure where you definitely should be enrolled in terms of having an ultrasound every 6 months, 6 to 12 months, 6 months really.
How many is that going to be though?
Sorry?
Out of 60, how many is that going to be?
Yeah, I haven't got that exact. I know that the age bracket's probably around 30 to 85 of the client group that I'll be looking at. But yeah, it may not be large enough numbers potentially as well. But what I can do is on that whole group, look at how many people have had an ultrasound, and then, or I can leave that to the second. I know that there is a gap. I know that even for people who are getting, say like a viral load test, ultrasound is a gap because it's just harder to access. The mobile ultrasound equipment is challenging. So that could come up in the second phase interviews, because I'll be talking to some specialists in the second phase of the work. So I know that's an issue. They need to look at how they're going to increase access for liver ultrasound.
You could have a treatment cascade. You could develop a treatment cascade. So
yes, there's some elements of that I could, yeah.
Diagnosis and treatment cascade, actually. Diagnosed, retained in care, engaged in care, monitoring pregnant.
And that's exactly what my understanding was, Michael, that
Yeah.
that you will be developing some bars of potentially infected. This is how many are turning up at the clinics.
Of the 60, how many are engaged in care? How many monitored?
Yep. And I have done some.
And of each step, it's a portion of each step.
Yeah. Yep.
So I might go down 60 to 40 to 35.
Yep. Okay, I won't show that. And I have done some starting work on some similar stuff to that. So
is this forming the whole of the PhD, this work?
yes. So the whole PhD now is going to be around hepatitis B management. How can we strengthen? I still want to have a strength sort of approach to this. So it's around not just the barriers, but how do we strengthen our hepatitis B management? And along with this work is that while I'm going in and collecting all this data, every single one of these clients' files that will be audited, we're also providing a series of recommendations for those clients' files, and ACTS is already offered as well to support every service with actually updating those clinical records on behalf of the service, if they would like us to, with those clinical items and those recalls. So it's part of a broader CQI project as well. But yeah, essentially I'm looking at the audit to find out what are our numbers like, what's our current care like, because we don't really know that. Then looking at the workforce perspective, which that workforce perspective has been done in a number of studies, but I'm hoping I'll add some different elements to it because they have been a bit more GP focused, a number of the studies. So I'm hoping, I'll draw in a bit more of a broad focus for an Aboriginal health worker practitioner.
There's another element to this, right? So AMS in South Australia.
Yeah.
If you think about the Atlas data.
Yeah.
We can see the number of patients that have been to the clinic over the last 2 years or whatever, and you'll be able to do this as you go along as well. You'll be able to see the number of patients who are susceptible to hepatitis B.
Yes.
So it's one thing to kind of look after the people who are negative, but it might be a nice analysis to get a full rounded kind of view of hepatitis B in ACTS by interrogating the Atlas data. Yeah. And so you can see the number of tests, and you can see they're negative for all 3 tests. Yep. And they're all susceptible to Hep B.
Yes.
So
so that's the first bar in the cascade.
Well,
these are the susceptible people, and out of this, these are the people who are benefiting from the system.
No, I think it's not the first bar, but it's kind of like
what can I say?
It's the background to vulnerability to hepatitis B in Aboriginal communities by they're testing 20% of patients. All of them are negative, right, and susceptible to Hep B. They've never had vaccination or been exposed to hepatitis B.
Give the context.
Yeah, so it's kind of like it's another part of that. It's not only managing these; they are testing. They are testing patients who they must think are at high risk, but they're not.
Yeah. So I've had to limit what I'm focusing on because of the PhD element and what's feasible within resources.
Papers in this, then? The one.
So my papers will be around the data audit, which will give us a lot of information on our numbers around hepatitis B, and it'll give us information on, well, what kind of care. So almost like the cascade around how many people that we have with the diagnosis are actually getting monitoring.
Yeah.
All of that information. The next phase will be, the next paper would be the workforce perspective then on all of this data. And so how can we, from a workforce perspective, the service perspective, so what are the barriers and how can we strengthen care?
And what's the next one?
And the next paper would be the client's knowledge and perspective. So I want to work with some people who have the diagnosis and maybe do some case studies. So that would be in relation to people's understanding of the virus. Looking at, well, if you for one client who has had all the correct tests, what was the factor for you, or what are the biggest factors? And so I think, and those areas have, this isn't necessarily a new knowledge area. However, within the area of hepatitis be, I'm thinking that will give some new knowledge in relation to, particularly because I'm collecting all this data, it'll give a very well-rounded case study. So that's the way I'm structuring the, but what I've got listed on this thing here, you see, James, is if we go down and see, I've got number percentage of clients in comparison to the current client population, because what I'm thinking this may indicate, is there a need for increased screening, or is there, further, research of the percentage of clients with the documented status? Now, you just said around a figure around 20% of people, say, who might be getting tested with negative for all 3 tests. Well, I've noted there that that's something I'm interested in, and it would be a good project to look at, to work with our sector and go through every service and do a complete review. And actually, they've made some pretty bold attempts in the Northern Territory, undertaking that work with a number of clinics, where it's actually a very comprehensive audit looking at everything, and actually determining then, okay, how many clients, not just with the diagnosis, but what are the other factors? However, that's a large project. It's worthwhile doing, and AXA would be
So
some.
this is the point. I'm saying Atlas is already collecting the data.
Yeah,
You've seen the
already.
report. You've seen the report. So all it is a chapter for your PhD.
Oh, okay, yeah. Yep.
Is an analysis of the AMSs in South Australia using the Atlas data to kind of give a very complete picture of hepatitis B management and care in AMSs. Because it's one thing to kind of look after the positive patients, but doctors have got some awareness about it because they're testing 16 or 18% of clients that come to the AMSs anyway.
So there's a risk.
On some suspicion that they might be positive, but to date there's been very few that have been positive. But I think it's another. It's one thing to kind of say, oh, you're not managing, or you're doing this well, or you're not doing this well for the clients, but actually they are doing a lot of other stuff as well.
Yeah, and
I think it'd be good for a chapter. It's easy, the data's there.
It's going to be pretty short. I mean, the comprehensive data you're talking about, that would be massive, but Atlas data.
Well, certainly if that's what, sorry, I was thinking in my head about something a bit bigger, but certainly, I'll be able to reference the Atlas data. It'll be, sorry, I've said this is another project which is, I probably haven't gone into enough detail here, but they're doing a
I'm hearing this
project.
interested. Actually, I see the importance of this as a contextual that what's going on at the
Yes.
overall community level. And there's a random, not random, but a risk-based testing. They have some criteria for who they should be testing, and all of that. It must be informing that what is the potential prevalence of this disease, and that would, if that could be done easily, accessed easily. It could be a few pages in your
I think you should consider it.
Yeah, I will definitely.
As a chapter. To round out the PhD, because one thing to do an audit on 60 clients for a PhD, but actually, and to kind of look at service perspectives and the clients, what's happening to them. I think you're doing a literature review.
Yes,
Yeah.
I've done that.
And then maybe an analysis of Atlas data around hepatitis B and South Australian services. Which six of
That
them
would
already.
be good, wouldn't it?
So this is across all health services or
Aboriginal.
Aboriginal? Okay, so that is also among the Aboriginal.
Yeah.
It would make sense.
So it's there's 6 in South Australia.
6 in South Australia.
Who's not in?
Talon and Rudy and
Not one Rundi.
Yeah, well, that's okay. We can look at that. I think that's definitely something to consider. Yeah.
It's straightforward.
Yeah, that's a really good point. So the other limitations. Okay. Well, so the other one I was saying is that more of that, there's large amounts of clients in a smaller number of services, so just how I balance that. And the other thing is that the audit work I'm doing is identifying other issues such as screening with incorrect tests and other things that don't really fall under management. And even like James said, some things that are getting done well, some things not getting done well. I still want to include some of that as contextual information, but it's not going to fit within the scope because it's just too much work otherwise to do it. The other thing which I haven't noted down there as limitation is the fact that within South Australia, by far our largest majority of clients is located on the API lands, getting managed through Nunapa, who aren't a part of this research. So I'm not going to be utilising this as describing as a statewide what's happening in South Australia. Because that wouldn't be representative necessarily, but potentially down the track, might do some work with
The nature of health system is such that there are certain special situations for a given client or a patient, right? So therefore, in one study, you cannot capture all the subtleties
Yes.
about patient care for a particular disease in a particular group of people, right? So therefore, for example, in any country or community I have seen, when the knowing the healthcare provider at a personal level, or knowing the health services where you have the capacity to pick up the phone and hello James, hello officer, hi Michael, I'm sending a patient to you, could you please look after? Doors open, okay? How you, this is not written anywhere in Communicare or any system.
Yeah.
So we cannot go
Yeah.
for that level of detail.
Yeah.
So if you can find out a generic picture that for which will be applicable to 90% of patients' care and improve that, I think that would be great.
Yep.
Yeah.
No, we should.
So
Definitely.
before you go, I think my understanding from today's discussion that you will need to write this note, so certain suggestion about the time frame, 2 years.
Yep.
About this very important highlighting of the issue that there is some risk-based screening happening, and that could be utilized for some work, and some information about this discussion about service variable and how it could be used as a situation analysis, and then the second phase as a narrative.
And the third thing, Afsal, is about getting my client definition very clear and potentially looking at what impact using a different definition works. So thank you for those once again. So I've taken on all the feedback from last time, so thank you. So this is now what I've produced. Hopefully this is a more academic piece of work. And thank you for the additional feedback from today. I think it'll be really good.
Thanks for inviting me, actually.
Yeah.
All right. Thanks, everyone. Just if Amanda or Annie, do you have any other
Sorry,
comments?
that took a while.
No, that's okay. That's all right. Any comments?
I couldn't quite follow what James was saying about the Atlas data and the Hep B data. Just to be aware that a lot of people wouldn't test for Hep B because they're already immune. So if they were immune 10 years ago, they're not going to do another test. And the other thing is, if someone's got a surface antigen that's negative, but they might have been immunised, and the theory is that if they did get in contact with Hep B, they would launch an immune system. So it's really difficult to work out that vulnerable population.
Yeah, and you're right.
Did I miss something, James, or I'm just a bit unclear?
I was suggesting that. I was saying that an analysis of testing rates within Atlas.
Within Atlas, just what's there?
No.
Is that the assumption that someone's testing because they're concerned that someone's vulnerable?
Yeah.
Perhaps. Yeah.
So it's highlighting, isn't it? It's, if this service has done no monitoring, for example, with hepatitis B, but they've done a lot of screening tests, well, it shows that there's the drive and the interest. It's just that there's a lack of education.
Okay. Yeah, I understand that dimension. Yeah, that would be quite good.
But you're right. It's very complex, Hep B, isn't it, in relation to
it's not easy.
Someone will have a surface antibody, but then 2 years later it's disappeared, and
will they?
Yeah, but
the specialists aren't in agreement about that either.
Yes, I know. So there's clinical guidelines, and then there's specialist opinion. So I don't know those lines.
Whereas we, in our service, we immunise everyone who has doesn't have surface antibody. We re-immunise.
Yeah.
You do one, then you retest, and they still haven't mounted an immune response, so then we do the 3. But other services, the NT guidelines are they should have been immunised, and you don't re-immunise.
Yeah, it's tricky. Yeah.
So.
Thanks, James.
But I understand what James is saying. Then it's more just like if people are testing, then they're thinking that the young person is vulnerable or the person being tested is vulnerable.
Yeah.
Okay. Thanks for that, Annie. Anything from you, Amanda, before we close? Okay. All right. And anything else from anyone else in the room? Claire?
I was just going to ask about if you want to have a week reflection done by the MD, Michael, how are you going on the ethics process?
Okay, so I am in the process of submitting I'm drafting my ethics. We've just gone through it today, so I'm hoping to submit that for the next AREC. So hopefully then I'll get that all approved. That'll be early November, so about the 7th of November. And then I'm told for the Adelaide University HREC, if I've got AREC approval, quite often the university process will be a bit smoother and I'll be able to go through it. Hopefully I can speed that process up. So hopefully I'll be able to start this maybe even mid-November.
Yeah, that's certainly my experience with Vickers. So when we've got all the AM stuff, it just stands the 2 weeks.
Yeah, so that's what I won't have to go to the full committee.
Yeah, that shouldn't be a problem. And I think to keep it easy, we have, our advice has been that take it one step at a time. Ethics review for the audit first.
Oh yeah.
Otherwise it will be
there's a huge amount of risks that come up when you're doing sort of if I was doing interviews, and what I'm proposing I want to do in terms of case studies with actual people, our community, I'm going to have to put a lot of time and effort into thinking about doing that appropriately.
There's an AMIC in November and you can be ready for that.
Yeah. And like I said, a lot of this sort of planning and stuff and the work and the data protocols with services, I've already sort of negotiated that and we've already been doing the work, but now I'm going to have to go back to services during this time as well and say, hey, I want to collect this additional information and then I'll have to get actual letters of support signed for the additional work. But I'm and that's 8 services. Maybe, hopefully all services will be supportive of me continuing this work, but you don't know. Yeah.
All right, thanks everyone. In the interest of time, we'll wrap this up. If anybody else needs to contact Michael, you know his email. Thanks everyone for attending this meeting. Thanks very much, Michael, supervisor, for coming. This has been a very useful meeting, I think, for Michael. I think we can say that it's been a very good meeting, yes. And thanks for presenting. I know you're very busy.
Right.
All right. Okay, and see you all in, I think, not November, but December. We'll send you an email.
Oh, okay.
Okay, all right.
Thank you.
Thanks, everyone.
Thank you, everyone. Bye.
Thanks, Michael.
Thank you for all the advice. End meeting?
Yeah.